Assalamu alaikum warahmatullahi wabarakatuh. Good morning, dear colleagues and friends, or good afternoon or good evening according to your time zone. Welcome back to our sessions for the part 2 and part 3 MRCOG candidates. This session will be the first session for the May 2025 candidates. Waiting, inshallah, for the results of November 2024 candidates. Wish you all the best of luck and all the best for the candidates who are going for the exam in next May. So the first task for this group will be about the WHO surgical safety checklist. Actually, it's not only about the exam. This is one of the very important topics to be discussed. This is one of the routine clinical daily practice that has to be done or practiced by any surgical provider to ensure the safety of the patient. This task appeared before twice. The first task was a complete structured discussion about the WHO surgical safety checklist in general. And when it appeared in the previous May exam in May 2024, it appeared as a part of the pre-operative gyne list. It has a big part of the marking sheet. So today we are going to discuss it in general, and in the core surgical skill module, we are going to discuss the modification that appeared in the recent recall. So when it appeared for the first time, it appeared as a structured discussion task. And as we know, in a structured discussion task, you will be assessed in the patient safety, in the communication with colleagues, and in the applied clinical knowledge. In this task, the candidate will play the role of ST5 in the preoperative clinic, preparing for the list for tomorrow. Here, the examiner will play the role of the lead of the risk management team, who are planning to integrate a formulated surgical safety checklist that's suitable for the unit activities. In the new task, it was not clearly mentioned that they will discuss the WHO surgical safety checklist. They mentioned that the risk management or the examiner is going to discuss with you or agree to undertake a non-technical skills for surgeon or notes or non-technical skills of the surgeon. Part of it is the communication during the surgery, which include the WHO surgical safety checklist. So here we need to summarize the principles of the WHO surgical safety checklist, the general principles, and what are the steps of successful integration or the use of the WHO surgical safety checklist in your unit, and how to guide any modification in the checklist to be suitable for the use in your unit. So let's go about the general principles of the WHO surgical safety checklist. So it is a safety tool to reduce the surgical morbidity and mortality, and it's now used by the majority of the surgical providers all over the world. So it is a safety tool or safety process, or it is an international standard to be used to ensure the safety of the patient before, during, and after the surgery. It was developed by the WHO Surgical Safety Checklist in 2008, and the aims of using the WHO Surgical Safety Checklist, number one, is to promote a culture of safety in surgical care. Number two, to decrease the errors and adverse events. If I'm going to open the discussion now, I will leave this for your comments under the video. How many errors in the surgical care were done? How many patients with similar names have undergone a wrong procedure? How many patients were going for a certain procedure and they had a wrong type of incision? So the WHO surgical safety checklist is used to decrease the errors and adverse events, to increase the team working, and to improve the communication between different members of the team during the surgery. So this is the history of the WHO surgical safety checklist and what are the aims of using it. The surgical safety checklist, it is composed of three main sections. These sections include the time of briefing, here we will call it sign in, then the time out, then the sign out. I was usually getting confused between sign in, time out, and sign out. Remember that when you are starting, you are doing sign in. When you are finishing, you are sign out. And in between, there is time out. These three sections are the main sections here. Under these three sections, there are 19 questions to be answered by the team who will be involved in the management or in the care of the patient. So three main sections, below them you have to answer 19 questions. In each section here, we have to mention what will be the time of this section, who will be there during this part, and what are the questions that needs to be addressed in this part. So let's start by the first section here, which is the briefing time or the sign-in. This sign-in has to be done before induction of anesthesia. So at least the 7 items that needs to be discussed here, it has to be discussed in presence of the nurse and the anesthetist. So at least the nurse and the anesthetist at the time of sign-in. The main issue here is to include confirmation of any known allergies, if there is any aspiration or airway risk, and blood loss. So the 7 questions that needs to be answered here. Number 1, you need to confirm the identity of the patient. In any list that you have patients with similar names, you should use triple identification of the patient. Do not only use the name of the patient to identify her. If there are similar names, you have to use triple identification. Also, you need to identify the procedure, the site of the procedure, and if there is consent signed or no. It is advised now to mark the site of the surgery to avoid any errors. You need to ask if there is any concern regarding the anesthesia machine and the medication, and the check is completed or no. You need to check if the pulse oximeter is attached to the patient and functioning, and you need to ask about any known allergy, as we mentioned before, any difficulty in the airway or any risk of aspiration. And as we are speaking here about gynae surgery, the risk of blood loss if it is more than 500. So in this case, you have to insert 2 IV cannulas, and you should have a plan regarding the fluid and the blood transfusion. So this is the first part of the WHO surgical safety checklist, or the first section, which is a time of briefing or sign-in. 7 items or 7 questions has to be answered here. It has to be done before induction of anesthesia in presence of at least the nurse and the anesthetist. The second part of, or the second section of the WHO surgical safety checklist is the timeout. Again, this timeout has to be done before the skin incision, and it has to be done at least in presence of the nurse anesthetist, and here we will add the surgeon plus the previous step. And again, 7 items or 7 specific questions that has to be answered by the medical professional. This part, it is mainly about the anticipated critical events, and there are list of related questions. These questions, again, you have to confirm that all team members have introduced themselves by name and role. So in the first part, we confirm the identity of the patient. Here, each part of the clinical team has to confirm his identity by name and role. Again, confirm the patient name, confirm the procedure, and where the incision will be made. Here you will have discussion with the anesthetist about the type of incision. Either it has been decided before the surgery, or it has to be decided after examination under anesthesia. Very important to answer if the antibiotic prophylaxis are applicable if it was given within 60 minutes before the skin incision. And now the critical events to the surgeon, to the anesthetist, and to the nursing team. So for the surgeon, if there is any critical or non-routine steps, how long the case will take, and what is the anticipated blood loss. To the anesthetist, if he has any specific concern regarding to the patient, and to the nursing staff regarding the sterility of the equipment, and if they have any issues on concern. The last point, if it is important for any imaging to be displayed, if it is applicable or no. So we finished now the time of briefing or sign-in 7 items, the time out 7 items, so 14 items are done out of 19. The last 5 items will be discussed at the time of sign out or debriefing. Again, what is the timing? It has to be done before the patient is allowed to leave the operation room. Here, 5 items has to be discussed in presence of the surgeon, the anesthetist, and the nurse. These items are mainly concerned regarding the recovery and the management of the patient after the surgery. So we have 5 questions here to be addressed. Again, the name of the procedure. The name of the procedure after the surgery may change. You may add any additional non-routine surgical steps during the procedure that may change the name of the procedure. Completion of the instruments and the sponge and needle count has to be confirmed. If there is a specimen, it has to be labeled and including the patient name, and if there was any problem with the equipments that were discovered during the surgery, it has to be addressed, and if there is any concerns regarding the recovery for the surgeon, for the anesthetist, or for the nurse. So these are the 19 items or the 19 questions that has to be answered by the medical professionals. These are classified into 3 sections at the time of sign in, time out, and sign out. So this is a general overview about the surgical safety checklist. If you are asked about it, you have to mention when it will be done, who should be there, and what are the steps or the question to be answered by the medical professionals. The second question of the examiner, how to integrate or how to facilitate the integration of the use of the WHO surgical safety checklist in your unit. There are 5 steps to effectively integrate its use in any healthcare institution. Number 1, we have to review the studies and understand the impact of the patient. Each one has to understand the impact of use in the patient. Then we need to mandate its use in the healthcare institution. And we need to get the buy-in of the medical professionals by presenting these studies and the best medical and the best practice in medical care. So review the studies, understand the impact, mandate its use, and present these studies and what is the best practice in the medical field. Then after mandating its use, you have to perform internal audits to ensure that it was used. From these audits, you need to analyze the impact of the use and the non-use of the WHO surgical safety checklist. What is the difference from using it and non-using it in the surgical care? And we need to discuss this impact with the medical staff again to ensure that they are using the WHO surgical safety checklist continuously. So number 1, review the studies and understand the impact. Number 2, present these studies to the medical team and mandate its use in the medical care. Number 3, perform internal audits. Number 4, analyze the impact of use and non-use. Number 5, discuss this impact with the medical professional to ensure continuous use. Now, this was about the general overview about the WHO surgical safety checklist. Now, adaptation. How to adapt the checklist to fit the use in your specific environment or surgical disciplines. So how to adapt the checklist to be suitable for a specific environment. Adaptation of the checklist is very important to better fit the needs and the process of care in a specific environment. The modification has to be based on the feedback from experts in clinical medicine and patient safety. And also, it has to be based on the feedback from those who had actually used it. So, the modification is based on the feedback from the clinical medicine and the patient safety people and from those who used it. There are principles when you are doing adaptation or modification of the checklist that has to be followed. Number 1, this checklist has to be focused. Focused, it means it should not include unnecessary items. So it has to be concise, including the most critical and the non-adequately checked safety points that were not checked before the surgery. Number 2, it has to be brief. Brief, each section should not take more than 1 minute to be completed. So number 1, it has to be focused, including the most critical and non-adequately checked items. Number 2, brief, not taking more than 3 minutes in total, 1 minute for each section to be completed. It has to be actionable. Means when you are asking or when you are adding or integrating a new question or new modification, you should have an aim. It has to be specific and linked to uh, unambiguous action. So there should be a concern and there should be an action that has to be taken regarding this concern. And this is a verbal exercise that has to be practiced by the team members, so it has to be collaboratives. It has to be collaborative between the nurses, between the anesthetists, the surgeons, and any other member that has to be added to the team. So each one will have the feeling of the ownership. And this is important for adaptation and permanent change in the practice. So till now, it has to be focused, it has to be brief, it has to be actionable, verbal, and collaborative. After integrating or adapting or formulating a new WHO surgical safety checklist to be suitable for the unit's activity, it has to be tested. And the testing through the real feedback of the clinicians or those who are using it. And it has to be practiced in simulation first till all the team members are comfortable with its use. Then continue this process until each one is comfortable that the checklist that you have created works in your environment. Each one in your unit will be comfortable with its use. So it has to be tested before its integration. Now, integration. We mentioned that the WHO surgical safety checklist has to be focused mainly on the team function and the communication. There are items that should never be removed from the checklist. Whatever you are going to adapt or formulate a new checklist, it has to include the team introductions. Each one has to introduce himself and you have to confirm the identity of each one of the medical team together with the identity of the patient. Pre-procedure information sharing, if you want to share any information between the nursing, between the anesthetist and the surgeon, and the discussion of the treatment plan at the end of the surgery. So these three items should never be removed from any checklist, whatever the adaptation that you are going to do it. After that, the institution will face the challenge of combining the pre-existing safety procedures with the WHO surgical safety checklist. So continuous implementation and continuous review of the impact of the use has to be there. So these are the steps that are used, or these are the main points that has to be there in any surgical safety checklist if you are going to formulate or to adapt it to the specific use of your unit. The next question for the examiner was, what are the points that can be added to the surgical safety checklist to be suitable for the use of the maternity unit? So here we will add some specific points that are specific to the cesarean section. So at the time of sign-in or the time of briefing, still the same points that we mentioned before in the general overview of the checklist, but here we are going to add the category of cesarean section. What is the urgency of cesarean? It is category 1 or 2 or 3 or 4. Here we are dealing with two patients, not only the woman. Here there is another patient, which is a child, that may need resuscitation. So if the resuscitative equipment have been checked and ready, and if the neonatal team has been called if needed. So at the time of sign-in, we can add the category of cesarean section, the resuscitation equipment, and the neonatal team informed or no. Regarding the time out, here we will add to the obstetrician, to the question that will be asked to the obstetrician if he has any concern regarding the placental side, because this will increase the risk. The same points for the anesthetist and for the nursing, but here we are adding the midwife. If cord blood sample is needed, if urinary catheter is draining freely, and if there was fetal scalp electrode, if it was removed before the surgery or before the cesarean or no, and if the VTE thromboprophylaxis has been undertaken for assessment or no. So these are the points that we will add at the time out, specific for patients going for cesarean section. At the time of sign out, here we will add, plus the 5 questions that we asked before, some additional questions for the midwife. If the babies has been labeled, if the cord blood has been taken, if relevant, and if it was taken, the cord blood gases has to be recorded. So these are the points that can be added to the surgical safety checklist, which will be suitable or which will be uh, integrated or modified to be used in the maternity unit. You will find different forms or different shapes of the maternity checklist that can be used in the maternity unit, but it includes the same items of the general WHO surgical safety checklist with some modification regarding the baby, regarding the equipment, regarding the neonatal team, and regarding the cord blood if it was needed. So this was a general idea about the WHO surgical safety checklist, again, as one of the processes to ensure the safety of the patient, as one of the international standards to ensure the safety of the patients during the surgery. What are the different sections of the WHO surgical safety checklist? Sign in, time out, and sign out. What are the 19 questions? 7 under sign in, 7 under time out, and 5 under sign out. These questions has to be addressed, and we need to know all these steps and how to integrate the 5 steps for integration of the use of the WHO surgical safety checklist in our unit, and how to modify or adapt the checklist to be suitable for the use of the maternity unit. As we mentioned before, this task contains 3 domains: communication with colleagues, patient safety, and applied clinical knowledge. So what are the points that needs to be mentioned here in the communication? You have to mention that the team introduction and the blessed planning are undertaken prior to the commencement of the surgery. So team introduction is very important. Each one has to introduce himself by name and role. You have to anticipate the critical events, and it has to be highlighted by surgeon reviews if the anesthetist has any specific concern, and the nursing if they have any concern regarding the equipments or instruments and their sterility. So the critical events has to be discussed. This is a point of communication. As we mentioned before, at the time of sign in, time out, and sign out, you have to mention the timing, when it will be done, who will be there, and what are the items that are included below each section. This is a structured discussion task, so you should explain or you should show your leadership abilities during the discussion. You should be a leader in the discussion, and you should respond positively to the examiner questions and speak an appropriate technical language. This is regarding the points in the communication. Regarding the safety, you have to recognize what are the steps of the WHO surgical safety checklist in general. And you have to recognize that each patient should have unique identifiers, triple identifiers, if there are similar names in the list, if it was part of the preoperative guide list. Ensure that you asked about the consent before the procedure. Ensure that you asked about the prophylactic antibiotic before the surgery if it was relevant. Ensure that VTE risk assessment has been undertaken and documented, and if there was any allergies. The blood samples for group and safe, and if there is any concern regarding the blood loss, and the items that should never be removed from any checklist when you are adapting it to use in your unit. So these are the points in the safety that has to be mentioned during the 10 minutes. The last domain here in this task was the applied clinical knowledge. You need to mention what are the aims of using the WHO surgical safety checklist in surgical care. You need to be aware of the items, the 3 sections, and the personnel that should be present during implementing each step of the WHO surgical safety checklist. You should explain what are the 5 steps for successful or for effective integration of the use in your institution, and the principles to guide the development and modification of checklist. And finally, what are the additional points that you are going to add to the WHO surgical safety checklist to be integrated for the use during the cesarean section list. So these are the points that has to be mentioned in each domain. Again, it's very important topic, not only for the exam, it's for the clinical practice, and this is one of the tasks that will make a difference between the candidates in UK and the overseas candidates, because this is not a routine practice in many units. Some of the candidates not aware of the WHO surgical safety checklist. Some candidates are not aware of the notes or non-technical skills for surgeon, including part of it, the WHO surgical safety checklist. When it was asked by the examiner in the exam, despite many of the candidates, they know the WHO surgical safety checklist, but they did not understand the question and they missed the points. And it was an easy task, but it was an easy abstain task. I hope that it's clear now for everyone. I hope that this session will make a difference if you face the task in the future. Thank you so much. If you find it useful, as usual, please remember me and my family in your prayers. Thank you so much and see you soon, inshallah, in another task. And Assalamu alaikum wa rahmatullahi wa barakatuh.